The other question which I commonly encounter after doing an angiogram and showing the blockages to the relative is, does this really require any kind of procedure? Can we manage with medicines? How sure are you that this lesion is critical? Should we really do something for this? And if at all, if we do a stenting, is it going to be a better result? Why not bypass surgery? Why do you think that stenting has to be done? And all these questions. So just to give a brief scientific evidence or scientific discussion on this, let me answer this. So blockages in the coronary arteries are an aging process, but can occur earlier in a patients who have certain risk profiles like diabetes, hypertension, smoking, or a family history, or a high cholesterol levels. So a block can be of a various degrees. We quantify that by a percentage of luminal compromise in the arteries. So this can be less than 50% or 50 to 70% or more than 70%. More than 70% is the one which is called as critical blocks, and less than 50% are the ones which are called as non-critical or a benign lesions. So when we say benign lesions are less than 50%, most often it can be managed with the medicines like blood thinning medicines, anti-anginal medications, and so on. So for those who are above 70%, there runs a risk of a heart attack or a recurrent heart attack if at all, if somebody had already had it. So this is where we would say that probably tackling that lesion is more important. So if at all, if there are multiple blocks, bypass surgery would be preferable. If it is a single or only a two lesions, tandem lesions, it can be tackled with stenting as well. There comes a gray zone that 50 to 70%, what do we do? So scientifically, it is difficult to answer this question. If at all, if somebody is not significantly symptomatic, then we would try to keep them under medical management, thinking that it is towards that 50%. If at all, if somebody had a significant symptoms, then it could be actually toward the 70% and angiogram has not depicted properly. Or it could be like this, the artery or a true artery is actually a 3D structure, and whatever angiogram we are going to see is actually a 2D picture. We might be missing out the third dimensional aspect. So how do we elicit this third dimension? So for this, we do have an intravascular imagings. Also, rather than imaging, we would also focus on physiology. So if at all, if we can assess whether the coronary flow or a blood flow through that lesion is really compromised or not, then that can give us an answer. So how do we do this? So we do a test called as FFR, fractional flow reserve. So as I said, it's a ratio. It's a flow reserve or a flow difference prior to the lesion and distal to the lesion. If at all, if the FFR value is more than 0.8, saying roughly that more than 80% of the flow is reaching to the distal coronary bed, then it can be managed with medicines. If at all, if it is less than that, then the blood supply to the distal myocardial bed or heart muscles is not enough, and that would need some kind of revascularization. So we also use intravascular imagings like an intravascular ultrasound or OCT, which is called as optical coherence tomography, which is a near infrared light based technology through which we can see the lumen of the artery very clearly and the walls of the artery very clearly. So we can identify each of the layers, we can identify what is the nature of the blocks, whether it is only a clot or is it a cholesterol deposit, is it a hardened cholesterol deposit which we call a calcified arteries or a calcified blocks. And then accordingly we can measure the length of the block, size of the artery, and then plan out for a stenting strategy. When we do this in such a planned way, the results of the stentings are going to be the best, so that the longevity of the stenting can be assured of, and also the post-procedural complications are going to be very, very meager. Studies have also showed that whenever the stenting has been done using these modalities, the results are much better and is equivalent to that of bypass surgery.